fact, after assuming the office of Presidency of Indian Academy of Pediatrics, this is the first time I'm addressing an academic forum. So the honors goes to Latur for the first academic. Otherwise, every time it was only administration, and I forgot that I'm also a pediatrician. P-meeting, head somewhere Divas Ratra. But then thank you for giving this opportunity, of course, to my dear friend Dr. Girish, Dr. Shiv Prasad, Dr. Sandeepan, and all of you in Latur, Dr. Deepika Madam. So great team efforts. A big round of applause for all of you for hosting this conference. Can we have the slides? So after this great session done by Jitu, Ganesh, Dr. Katke sir, everybody, a wonderful vaccine technology, we are straight away moving into a different arena, UTI. I have been given 20 minutes. So I have to talk about complete UTI, what's new. It's a little difficult task that I can think of, but still let me see how best can I tackle this, because there are so many new things which have come up in the management of UTI. So all of us need to remember this one single bold statement in bold, absolutely. Single confirmed UTI should be taken seriously, especially in young children due to the potential of renal parenchymal damage. I think that's so important. A single confirmed UTI, especially in young children, has a complete potential. So we are handing over our pediatric patients after 18 years to our adult colleagues, and we do not want even that single episode can have catastrophic effect on the kidneys of that child when he turns adult, or many times before also, because we have missed opportunity to investigate this child in detail. So that's the first thing. So these are the guidelines that we always had. The first, and these are not yet revised. Mind you, in 2001 and in 2011 we had second one. But these are the new ones, but of course by the Surgical Society, Urological Society. But fortunately, the Indian Society of Pediatric Nephrology has revised these guidelines, though they are officially not out. But with help of couple of case scenarios, let's see how best we can cater to. All of us know that we do not want the percentage of how many 2 to 7%. Each one of us has seen a single culture-proven UTI in our day-to-day practice. We know it's a very, very common disease to have, and let's see how best we can cater to them. So let's start with 2-year-old child. Female child has come with fever of 101 or 2, severe abdominal pain. I do a urine routine which shows 15 to 20%. Is it UTI? The urine routine shows 15 to 20% for high power field. So this is Pittsburgh University has come out with a great UTI calculator. You can download it from Google also. Look at this, what it has said. Which are the patients that you should seriously think of UTI? Number 1, age less than 12 months. Number 2, temperature has to be about 102. So 9900 very unlikely to have UTI. So look at the factors which are important. A past history of UTI, of course, you should again next time should once a UTI, next time the fever मी नेहमी सांगतो पुन्हा ताप येईल पहिलं युरिन रुटीन करायचं एकदा कल्चर प्रूव्हन UTI असेल तर. फिमेल और अनसर्कमसाइज आपल्या इथे ह्याच्यात फार डिफरन्शिएट करत नाही आपण, पण तरी देखील हा फॅक्टर महत्त्वाचा. अदर फिवर सोर्स. So I have a dengue and if I have a Kawasaki and I get urine routine 15-20%, I don't go into this could be a UTI. I know very well that it could be assessed. So other fever source unlikely. Duration of fever more than 48 hours. Very important. So maybe these are the factors that if you put in together and probability. So if I put, and these are the factors, look at the pre-test probability, it's only 1.83%. So you can very well put this. So please note this probability of UTI is very low, it will come out. The window will pop up over there. Many clinicians not even would do urine routine or culture in this patient. So only on the basis of these factors you can very well determine, because प्रत्येकाची urine culture करणं is impossible. Unnecessarily you are wasting our resources. So try to categorize. Probability of UTI is so less in this patient. Let's go to the second patient. So 2-year-old healthy female has come at 11 p.m. at night. So the rapid diagnostic test for malaria is negative. Sample for dipstick is asked for. Urine dipstick nitrite is positive. Culture is collected. Put on antibiotics. Is it UTI? So how useful? How many of you do dipstick in your OPD? Have you kept dipsticks? Very easy, very cheap. Doesn't cost even 50 rupees per patient if you see. Especially at 11 p.m. If the patient comes straight away, you can do it. So we can very well have at least a first test probability. Of course, culture will always remain the gold standard. So what is it? So this is the one which I always skip in my OPD. So leukocyte and nitrite. Urine culture, of course, gold standard, but it takes 48 to 72 hours. So what do I do? So nitrate test, look at the specificity of 98%. All of us know that infants, they need to hold the urine for at least 3 hours for this to become positive. Completely agree. But if it comes positive, negative does not rule out, but if it comes positive, 98% is close to 100% specificity, and if I combine it with leukocyte esterase, the sensitivity is almost 100%. So friends, try to keep these dipsticks with you at odd times or even during OPD hours also, so you yourself can do this test and see that the patient, and then of course subsequently you can do the culture and you can confirm the diagnosis. Now 3-year-old child comes with fever for 3 days. Routine shows 5 to 6%. Culture asks it has grown 10,000, the colonic count. So now is it UTI? So all of us know the typical words that suprapubic, anything which is grown, catheterization about 50,000, but then 10⁵ for midstream. So midstream clean void catchment sample is the one which is most important. But what about the others? Do I discard them? So then what is it? So generally 50,000 and higher represents a significant growth. But mind you, if the patient is immunodeficient, has UTI abnormalities, taking antimicrobial therapy, even a lower count cannot be discarded. So more than 10⁵ midstream clean cat sample is a must. We do not do suprapubic for every patient. Maybe in an ICU setting where I must want a culture sample immediately, probably okay, but otherwise midstream clean catch, and this is how we are supposed to interpret. Now, having considered all this up till now, we have talked about clinical, we have talked about urine routine, we have talked about leukocyte esterase. How would my flow chart be? A child has come without fever, of course, without source is very good. UTI is without source. And we are talking about young babies. The older children will have the tenderness, dysuria, urgency, frequency, hesitancy, all will come. But what about younger child? I do not have anything else. So here in specific urinary symptoms or risk factors, do a culture and dipstick test. So dipstick is positive, start empirical antibiotics, do culture. Culture is sterile, stop antibiotics. But dipstick, if it is alien nitrate negative, age less than 6 months or risk factors, no, then wait for culture. But yes, then you do. It does not matter for CSF, it does not matter for blood culture, but for urine culture, this is a very important part. Now oral agents remain the same, and मी तरी गेली 20 वर्ष जवळपास cefixime is the drug of choice for any such UTI. The only thing now it has come that like amoxicillin for URTI and tonsilopharyngitis, 8 mg per kg in a single dose also. This is an up-to-date guideline, which also even the AAP guideline, sorry, that this says that single dose of cefixime is also good enough as oral treatment for UTI. Rest, I have sometimes used amoxiclavulinate, but otherwise other antibiotics, though they are okay, but I have never used in my practice. Going to injectable, all of us know, and there is a difference between the in vitro and in vivo sensitivity. Sometimes you have put the patient on ceftriaxone, the report may come resistant, but still the patient will be positive because the concentration required in kidneys is much different than the sensitivity which is done in blood. So that's why you will get in vitro. Actually the patient is responding. So do not change the antibiotic just because the culture reports. By that time 48 hours have gone, patient has responded to ceftriaxone, switch over that child to cefixime rather than subjecting them to aminoglycoside. That is number one. So confirm the cure. Every time, do I need to do a culture after this? Is it a must? No. Culture to prove that this child is cured. We do it in CSF in a neonate. We do not even do it in CSF of a bacterial meningitis of an older child. So periodic urine culture, which group of patients? So this is not a must. Patients going to be responding to the antibiotic properly chosen in proper doses for proper duration. 68% most of the patients become afebrile in 24 hours, 89% within 48 and 92%. ह्याचा फायदा काय होतो क्लिनिकल प्रॅक्टिसमध्ये 72 तासात माझ्याकडे कल्चर सेन्सिटिव्हिटी रिपोर्ट आहे, दूध का दूध पाणी का पाणी, अरे तापच कालपासून येत नाहीये, परफेक्ट. सो वॉट एव्हर आय हॅव स्टार्टेड, इवन वॉट एव्हर दॅट कल्चर रिपोर्ट शोज, आय मस्ट कंटिन्यू. दॅट इज व्हेरी इम्पॉर्टंट बिकॉज दिस लास्ट वर्ड 72 hours मध्ये 92% they respond. That's so reassuring. Moving ahead, so this is a Milwaukee study. Is it a must? Follow urine cultures for those in whom the expected clinical response not attained within first 2 antibiotic days, none were positive. So it is not at all required to do a follow-up urine culture of patient. So कुणाचं परत करायचं repeat? These are the patients, complicated UTI, resistant uropathogen, on antibiotic breakthrough असेल, urologic malformations at less than 3 months, immune deficient. So these are not our routine patients. So these are the patients probably I may have to do a repeat urine culture, otherwise not in every patient. Investigations, what is new? This is the thing. This is one condition where you cannot only diagnose UTI, you cannot only treat UTI, but you have to follow, because of that, my first slide of potential to cause renal parenchymal damage in every patient. So what were we told up till now? गेली 20 वर्ष हा प्रोटोकॉल मी आणि तुम्ही सगळेजण फॉलो करत होतात की एज लेस दॅन 1 इयर फक्त USG नाही, तिन्ही गोष्टी करायच्या. इनफॅक्ट वी सब्जेक्टेड एव्हरीबडी टू अल्ट्रासाउंड, MSU, DMSA स्कॅन 1 to 5 years, दोनच गोष्टी करा. त्याच्यामध्ये काही पॉझिटिव्ह आलं तर पुढचं करा. एज लेस दॅन more than 5 years, do only USG. So this is what we were doing. Is it a must to do all these things? Because remember that MCU and DMSA scan have a potential to have radiological exposure. So that is very important. Is it a must to do all these things in every child? ह्याच्यावर खूप विचार मंथन जगभरात झालं. And what people felt, now this is the new algorithm which has come, that if it is a first episode of UTI, assess for bladder bowel dysfunction. This is so important. One of the important factors to rule out this. So recurrent UTI असेल किंवा तुमच्या कल्चर रिपोर्टमध्ये E. coli सोडून काही आलं असेल, whether it is Klebsiella, whether it is Proteus, whether it is Pseudomonas, दूसरा कुठलाही ऑर्गॅनिझम असेल, take it very very seriously. E. coliच बहुतेक वेळा येतो. So but then that does not it is not a must for you. So non-E. coli UTI in less than 2 years of age, yes, I have to do everything. So not only USG, I have to do MCU, I have to do DMSA scan also. If not, if it is only a first episode, I will stop at USG itself, and only when the USG is abnormal, then MCU, then DMSA, recurrent episodes are symptom. I think very simple. So do not subject every patient to DMSA and MCU that we were doing earlier. The criteria for doing these tests have become very limited. So commonest predisposing factor. Can I just have an audience poll? Which is the commonest thing that you come across when you come a patient of UTI? की त्याला काही विचारलं की बहुतेक वेळा that comes as positive history. वा वा वा, जोरदार टाळ्या सगळ्यांनी आपल्यासाठीच वाजवा. परफेक्ट. बऱ्याच वेळा लोक हे उत्तर देत नाही, बट व्हेरी इम्पॉर्टंट. दिस इज अ वंडरफुल गोल्डन स्टेटमेंट. एकदा मी AAPची अॅन्युअल कॉन्फरन्स अटेंड केली होती, तेव्हा हे तिथे बघितलं. अँड एम्प्टी ब्लॅडर मीन्स अ हॅपी ब्लॅडर, बट अन एम्प्टी रेक्टम इज इवन अ हॅपियर ब्लॅडर. इतकं महत्वाचं गोल्डन स्टेटमेंट आहे. दॅट डू नॉट ओनली ट्रीट UTI बट ट्रीट दॅट बॉय. कॉन्स्टिपेशन ॲड्रेस केलं नाही तर तो परत परत येत राहणार आणि आपण हमखास हे विसरतो. सो नेवर एव्हर फॉरगेट ओनली ट्रीटिंग द UTI बट ऑलवेज टेक केअर ऑफ कॉन्स्टिपेशन. सो व्हॉट आर द थिंग्स फॉर ब्लॅडर बॉयल डिस्फंक्शन? व्हेरी इम्पॉर्टंट. फर्स्ट स्टेप्स इज timely avoiding scheduled voids every 2 to 3 hours. Double voiding. This is a great technique and it is really useful. Asking the children to sit and urinate again right after. थोडीशी राहिलेली असते आणि मग ती स्टॅग्नेट होऊन UTI होतो. And avoidance of carbonated, caffeine, citrus, chocolate, food हे अतिशय महत्त्वाचं आहे. So total avoidance of that, and of course laxative for a longer period of time. 1-2 आठवडे महिन्याने काही होत नाही. 4 ते 6 महिने कॉन्स्टिपेशनची ट्रीटमेंट करायला लागते. So prophylaxis, this is another thing. When, which and how long, this is another thing. So we always used to give prophylaxis to all these patients to wherever the reflux was of a higher degree. I remember that chemoprophylaxis, younger age group मध्ये cefadroxil or we used to give cephalexin. Older age group मध्ये when I started practice, trimethoprim sulfadoxazole was the commonest one, and rest of the things of course nitrofurantoin. But the biggest disadvantage of nitrofurantoin is the test. Most horrible testing antibiotic in the world could be, I can say, nitrofurantoin. इतकी भयानक टेस्ट आहे त्याची. But then it is great as far as chemoprophylaxis, and we need to subject. So which are the patients that I am actually going to subject to? So look at this. This is a great reassuring thing. We used to give so much antibiotics. We are talking about judicial antibiotic therapy. In fact, मगाशी एक गोष्ट मला बोलता बोलता राहिली की एम्पायरमध्ये बोलताना सर म्हणाले होते की नाही सॉरी ॲक्यूट अपेंडिसायटिस पहिली केस होती सर्जिकल पॅनलमध्ये की अँटीबायोटिक लाईक मेरोपेनल पण चालू शकतं. पण लेट्स नॉट ऑल ऑफ अस यूज अवर अँटीबायोटिक्स judiciously. So ceftriaxone and metronidazole are good enough, if not a piperazine and tazobactam, but a carbapenem for acute appendicitis is not absolutely, none of us give it. So I just wanted, पण तेव्हा वेळ नव्हता म्हणाल ते राहिलं बोलायचं. पण this is another thing. Antibiotic prophylaxis इतक्या जणांना आपण दिले आतापर्यंत. Is it really effective? Look at this. More than 5,500 doses of antibiotics are needed to prevent a single UTI. 5,500 doses. Isn't it too much for every patient after positive UTI? Earlier we were told प्रत्येकाला द्यायचे antibiotic prophylaxis. Antibiotic prophylaxis has not. We are worried, you and I are worried about renal scarring, which is going to have that final renal parenchyma damage. I do not want to have that. So that's why every patient does not justify to have this preventive antibiotics. So twice daily administration which lead to antibiotic resistance,
and all these patients are more likely to have a resistant bug growing in the urine rather than your benefiting. So considering all these matters, so decision is always controversial. When considering option, clinician should take into account each child's unique characteristics, involve the family in decision. हार्ट स्पेशल असेल त्याला PU वॉल्व आधी होता, हार्ट स्पेशल त्याला रिकरंट UTI होता, हार्ट स्पेशल त्याला हाय ग्रेड UR होता. I have a different criteria, but if it's not a garden variety of UTI after the first episode, I need not subject them to antibiotic prophylaxis after the first episode of UTI. So while final take home and final slide of my presentation about approach to treatment of UR, all of us know higher grade of reflux is very bad. 1 or 2, in fact it has been said at the randomly patients करायला सांगतात त्यांची कितीतरी जणांचं तुम्हाला 1 or 2 grade मिळेलच. So that's why we do not, that's another reason why they have restricted every patient should not be subjected to 1-2 जरी डिग्री अरे थोडं तरी देऊन टाकूया वर्षभर 2 वर्ष. That should not happen. So primary VUR if it is there, low grade 1 or 2, no UTI, no antibiotic prophylaxis. So routinely तुम्हाला जर USG मध्ये आढळलं तरी अजिबात देऊ नका. ब्लॅडर बॉयल डिस्फंक्शन नसेल, नो अँटीबायोटिक प्रॉफिलॅक्सिस आहे. अँटीबायोटिक प्रॉफिलॅक्सिस स्टील रिझोल्यूशन. त्याचं कॉन्स्टिपेशन जर झालं की डज नॉट हॅव एनी अदर चॅलेंजेस, यू कॅन व्हेरी वेल स्टॉप इट. नाव कम्स द इम्पॉर्टंट क्रायटेरिया वेअर आय शुड ॲक्च्युअली गिव्ह दिस अँटीबायोटिक. हाय ग्रेड, grade 3 and grade 4, they are really bad, and then there is no anti-BBD dysfunction. You have to give it for 2 years. So 1 year from your last episode of UTI. So limits are period. If you remember the earlier recommendations were up to 5 years. Yes, there are antibiotic prophylaxis. Now it has come to, if there is no BBD, then you can give it only up to 1 year from the last UTI. But there is still bladder bowel dysfunction, and this also involves dysfunctional voiding also. Remember that the patients do not actually have problems in actually getting UTI, but they have problems in voiding. So always the urine remains there itself. So if there is a bladder bowel dysfunction, I have to give this antibiotic prophylaxis till there is resolution, complete resolution of bladder bowel dysfunction or a VUR, which becomes 3 to 2, 2 to 1, then that's a different story. But 4 to 5 automatically converting into lower grades is unlikely. So these are the patients, those who have recurrent UTI, no BBD, you may have to have ureteric reimplantation, endoscopic injection. So basically grade 3, 4, 5, you have to have a pediatric surgical colleague on board for consultation, and he has to be, he or she has to be involved when taking final decision. So friends, I feel that even if I was given 20 minutes, I could manage to give you an overview of what is UTI, how the clinical guidelines could be set, which are the patients to give, subject them to microscopy, how to take use of the dipstick test, what are the precautions for culture, which drugs, antibiotics for treatment, chemoprophylaxis, and finally imaging and final modalities of treatment to this patient, not to forget about constipation. So thank you very much for your patient hearing. I must give you an invitation. See you all very soon in Gandhinagar, in Ahmedabad, Gujarat, state of Gujarat, in Mahatma Mandir Convention Center. I am sure all of you have registered. If not, there is a possibility of registering virtually also. IIP members फक्त 4,000 रुपये आणि 3 महिन्यापर्यंत you can see all the sessions, recorded sessions. Students ना 2,000, IIP members ना 4,000, non IIP ना 6,000. So जरी अजून थोडीशी भीती असेल बाहेर ट्रॅव्हल करण्याची किंवा आता केलं नसेल, because the slabs have gone up, I have request each one of you to at least register, be a part of this forum. Thank you again. Thank you so much.
Thank you, sir.